medication. And today I'll be talking along with my colleagues, of course, after my colleagues, about nasal health challenges. I will just have a summary of the information that they discussed. And of course, I will add some important points, some cases that we will enjoy together. And hopefully, we will have good participation and attendance as usual. So thanks a lot for handing on to invite me again for this valuable session. And I will be starting with my talk about the nasal decongestant, as my previous colleagues mentioned, Dr. Isam and the previous doctor as well, our famous pediatric physician. These are medications that are used to relieve nasal congestion, of course, in the upper respiratory tract. The mechanism of action probably the pharmacists are expert in targeting or talking about the mechanism of action of nasal decongestant in general, which is the activation of the alpha adrenergic receptors that are found on the recapillary and post-capillary blood vessels of the nasal mucosa. So probably if we understand the mechanism of action, we can probably provide more education to our patient to minimize the side effects that could be due to these medications in general. The classification of the medications are that are nasal decongestant are adrenal release agents, which are, for example, ephedrine, levomethamphetamine, pseudoephedrine, alpha adrenergic receptor agonists such as xylometazoline, which is the famous medication, or oxymetazoline. And of course, we have the corticosteroids, which are fluticasone, beclomethasone, etc., and prednisolone. The adrenaline release agents, just to talk a little bit about them, ephedrine is the major one, which is the principal mechanism of action is basically to or relies on the indirect stimulation of the adrenergic receptor system by increasing the activity of norepinephrine. And this is where the side effect that come from this type of medication is understood, which are, for example, increase in blood pressure in certain patients. Ephedrine stimulates alpha adrenergic receptors and blood vessels of the nasal mucosa, which basically produce vasoconstriction and nasal decongestion in general. One thing that I want to highlight is basically the pharmacological action on different organs, and the major organs are going to be the heart, the cardiovascular system, which basically the ephedrine that acts on the beta adrenergic receptors on the heart, which produces a positive inotropic effect on our patients. On the brain, on the other side, ephedrine activates the pathway in a human brain that are responsible for weight loss mediated through the beta-2 receptor as well. On the smooth muscle, ephedrine relaxes the smooth muscle of the GI tract by stimulating also the alpha and beta-1 receptors. On the blood pressure, on the other side, ephedrine shows biphasic response, which means ephedrine at low doses will basically cause decrease in blood pressure, whereas at high doses will increase the blood pressure. So we have to be also aware about education of our patients toward the hypertension that could be caused or elevation of the blood pressure with these medications. So the main point that I want to discuss with you is basically the history of the patient. Always ask the patient before giving those medications is the common questions, the medical history. Do you have a history of high blood pressure? Do you have a history of cardiovascular abnormality? Do you have any type of organic heart disease? Do you have CAD or coronary heart disease? Do you have angina? So all of these are required questions to be asked by the pharmacist or us as healthcare provider before we give those medications to patients. And of course, one other point to remember is to ask the patient if they have any type of eye problem, like glaucoma. Did they have any type of eye surgery before? All of these are questions that we need to ask. Levomethamphetamine is another sympathomimetic vasoconstrictor, which is the active ingredient in some over-the-counter medications or nasal decongestant, basically in the United States and other parts of the world. It basically temporarily relieves nasal congestion by constricting the blood vessels in the nasal mucosa. And of course, the alpha adrenergic receptor agonist, basically phenylephrine is one of the major basic ones, or the elderly or older one, I want to say, which was approved in 1976 for nasal congestion. It's a medication primarily used as a decongestion or as a decongestant to dilate the pupil and to increase basically blood pressure. Uh, this causes, on the other side, a vasoconstriction, which leads to decreased edema and increased drainage of the sinus cavity, which basically what causes pain in patients that suffer from sinus issues, and they seek pain relief when they come to us to the pharmacy. Oxymetazoline is basically the most famous one that patients come asking for. It binds to activate alpha 2 adrenergic receptor upon nasal administration. This constricts the arteriole in the nose, decreasing the nasal congestion. And of course, it's available over the counter as a nasal decongestant in the form of oxymetazoline hydrochloride, which is mainly accessible by many patients. We have, as my previous colleague mentioned, the xylometazoline solution to relieve nasal congestion, like medicated xylometazoline. This was discussed previously by my colleague, which also xylometazoline with ipratropium as a combo medication for nasal congestion with runny nose, and of course xylometazoline for adults and xylometazoline for pediatric patients as well. Now, let us, since my colleagues talked about the allergic rhinitis and talked about rhinosinusitis, and they discussed the difference between seasonal allergic rhinitis and perennial allergic rhinitis. So probably jumping to case studies is a good thing to basically have a thorough discussion together, and to give you a chance for amazing poll questions as usual. So our case is called allergy-related nasal congestion. We have RS as a 38-year-old woman who has a nasal congestion and typically has seasonal allergies. So these are things to remember related to our case. RS has been taking loratadine 10 milligram daily for the past few weeks, but has had no relief. She wants to know if there is anything stronger she can take over the counter. What recommendation should the pharmacist make for this patient? So again, just to remember, we have a patient that is a 38-year-old woman. She has a nasal congestion and she has seasonal allergies. She's taken loratadine, but she's coming to the pharmacy, of course, typically as a patient asking for a recommendation from us as pharmacists. So some of the important points to gather before we jump into conclusion is to question the patient and gather some details to know the history, to know more information about her situation. RS is suffering from mouth breathing and poor sleep. Also, as our two doctors mentioned, that the nasal congestion can affect the breathing at night, can basically affect the quality of the sleep or lead to inappropriate sleep hygiene, we call it. The second thing is that she is sneezing more often lately. That's number two. She has a bit of headache and facial pain, which is typical with nasal congestion because of the blockage also. And many patients come to me, come to also my colleagues, other healthcare provider, suffering from severe headache and facial pain and asking for painkillers over the counter. Her nose is blocked completely. So this is one thing also that I wanted to share with you that also was discussed a little bit by my colleagues, which are to ask for a detailed patient history before we decide whether we want to recommend a medication over the counter or we want to refer to an ENT specialist like Dr. Isam. So upon detailed patient history, we need to ask about nasal blockage, about the discharge, about the presence of facial pain and headache, about eye symptoms, as mentioned before, and of course, about current medications that the patient is taking, physical examination. Has she done physical examination before? Or try to examine if there's any type of edema or swelling on the face. Then check for the presence of worrisome symptoms like the red flags that we talked about, which are, for example, epistaxis or bleeding. Check for eyes like swollen eye or eyelid. Check for double vision. check for also type of coughing, etc. So if the answer is no, definitely we will try a medication. And if we try a medication and there is treatment failure, definitely we recommend referral to an ENT specialist. And of course, if the answer is yes, any of these, we directly refer to an ENT specialist for further investigation. So my question to you for the case number one is basically, after asking all those questions and getting the information from our patient, which of the following are appropriate treatment option for RS? The first option A, it's because she's already taken an antihistamine, she should try an FDA approved intranasal corticosteroid. That's option A. Remember, she has tried the loratadine before. B, RS can try any of the intranasal corticosteroids, as all of them are twice daily medications. That's number B. Number C is if her symptoms do not improve, RS should see her primary care provider or an ENT specialist. Or number D, A and D are correct. So I will just give you 30 seconds to think and let me know what is your answer. Okay, waiting for your answer, and I'm trying to open your the slide. I think I got a little bit of a jam here from my side, but let me see again. Can somebody share with me the answers of the respondents, please?
So, Dr. Anna, for option A, we have 15%.
Okay.
B, 8%.
Okay.
7%, and the most of the people, around 70% answered.
Okay, great. The best answer will be option D, which is basically A and D are correct. The patient has already tried antihistamine. She should try an FDA-approved intranasal corticosteroid, which is a very good option. Of course, number B is not correct because the intranasal corticosteroid are approved, but all of them are once daily medication instead of twice daily medication. So this is something to consider and to think of. And of course, if according to the guidelines, if her symptoms do not improve, she should see her primary care provider as soon as possible and do a further investigation on her. So this is for this case. One thing also I wanted to share with you is the allergic rhinitis questionnaire. And I found this questionnaire very useful because to know if the patient has allergic rhinitis and to dispense a medication for over-the-counter for allergic rhinitis is something crucial before we direct them for other options. So this simple questionnaire simply asks first, does the patient have any of the following symptoms, which is symptoms of only one side of the nose, like that is blocked, nasal obstruction without any other symptoms, there is any type of thick green or yellow discharge from the nose, is there any type of postnasal drip or with the thick mucus, is there any type of facial pain, is there any type of recurrent nosebleed or inability to smell? And I believe that all of you agree with me that if any of the answers to this question is yes, definitely this is not allergic rhinitis. This is something else. This is congestion, of course, and it's not allergic rhinitis. Well, the other part of the questionnaire is that do you have or does the patient has any of the following symptoms for at least 1 hour on most days of the week, or on most days during the season if your symptoms are seasonal, for example. If the patient has watery, runny nose, sneezing, especially violent and bouts, the patient has nasal obstruction, nasal itching, or conjunctivitis. So the main point also I wanted to share is there is a scoring system with this allergic rhinitis questionnaire, is that the presence of any one of the symptoms listed in question 1 suggests that the patient probably does not have allergic rhinitis as discussed, and of course alternative diagnosis should be pursued. Allergic rhinitis is the likely diagnosis if the patient has watery, runny nose, and more than or equal to one of the other symptoms listed in question 2, which is basically helps us a lot to diagnose or to figure out if we need to give a medication for allergic rhinitis or we need to pursue other therapy. So this is why I wanted to discuss this second case with you today, and I hope I'll be able to open the poll questions. If not, I will ask some of my colleagues, my assistant, my hidden angels working in the back, of course, to help me with figuring out your answers. So the runny nose and nasal discharge. This is a patient who is TS, a 37-year-old man, is looking for a recommendation for treating his runny nose and clear nasal discharge. So that's number 1. He says he experiences these symptoms annually around the same time of the year, adding that he's also suffering from irritated, itchy eyes and a sore throat. TS says the symptoms are so bothersome that they are interrupting his sleep at night and causing daytime drowsiness as well. He wants something over the counter that will alleviate his congestion and allow him to sleep normally, and does not want to see his physician if possible. Probably it could be to lack of time, no insurance, etc. The pharmacist is more accessible. So these are all reasons for accessing the pharmacist maybe at times for if there is no need for referral. Now, TS reports no significant medical history, and that's an important thing to discuss or to ask, and says he does not use other non-prescription or prescription medications. So this is also vital. What self-care recommendation can you provide? And this is for you as a pharmacist. What is your option and what you need to provide to this patient? So which of the following is false options? So which one is false? Let us go over them together. First, TS, clear nasal discharge and cyclic seasonal symptom occurrence are characteristic symptoms consistent with allergic rhinitis. You agree or you don't agree? That's number A. Number B, recent evidence suggests that to manage seasonal AR symptoms, combination of medication from these classes should be used rather than monotherapy, what medication? These are the antihistamine and the corticosteroid, based on a lack of superiority of the monotherapy in reducing symptoms. And I want you to focus a lot. And if you are up to date with the evidence and the guideline, you should be able to know this question. Number C, it should be C, of course, ABC. Ocular symptoms, of course, can be particularly troubling as well. For persistent eye symptoms, an artificial tear solution or topical medication could be used, like ketotifen could be used for this patient. So which one is false, not true? I will wait a little bit to have your precious answers. I will try to open it from my phone, and I'm glad to see that it's opening from my phone, which is great. Now, the answers are the following. I see that 29% answered option A, 53% answered question B, and of course, question C was for like 17%. And I'm very glad that the majority answered the right question, which is at least 50%. And definitely why this is false, because the recent guideline or the guideline says that there is no evidence that using a combination of both is better than monotherapy. Monotherapy is sufficient. You can use either intranasal corticosteroid or antihistamine to relieve the patient's symptoms, and the patient should be fine. Of course, A and B are correct. So with this second case, I'll be glad to end my talk. I hope I didn't take too much of your time. It's